Good morning, Sages family. It's our great privilege this morning to welcome our president, Dr. Liane Feldman. I'm going to have the privilege in the next few moments of just setting the stage for Dr. Feldman, telling you a little bit about her and rehearsing a little bit of the details of her life. A few things about Liane, and by the way, I want to thank her husband, Hillel, who's sitting down here with her this morning. He was an incredible help on filling in some details. But as you can see, even in her early years, Dr. Feldman exhibited many of the qualities we as a society have come to appreciate about her. Her evident joy in life as a one-year-old, that contemplative, thoughtful aspect as a 3-year-old, and I wasn't quite sure how to fit this in, but she loves purple, and maybe that was a clue that this was future royalty. Her family, some of whom are with us today, but some of whom will not be, but hopefully are participating remotely. Ron and Sandra, her parents, her brothers, Adam and Jamie. You can see that she was the big sister and the mentor, I think, to her siblings even as a young child. There were some early indications that there was something special about this lady. You can see her in scrubs. She loved scrubs for some reason long before surgery, I'm sure, was on the horizon. Even in medical school, surgery was kind of a late bloom, as I understand it. But somehow she knew she belonged in that uniform. And the other thing that's really interesting is not because she was trying to make a statement, but in a theme that really comes up again and again in Liane's life, because it looked fun and she wanted to do it. She was the only female player on a boys' hockey team. She carried that on into intramurals in college, where she was part of a couple groups. I think they were called Babes with Blades and Chicks with Sticks. But you get the impression this is not somebody you want to mess with, and who has the initiative to do bold things just because she wants to do them and is not deterred because others say that that isn't the way things go. This continued to blossom in her years at Brown. You see a picture of her there. She took a semester abroad in Bali, and this was really an important season in her life. She learned the local language. She obtained a much broader view of culture and different views of our life and worldviews, and she obviously blossomed as a scholar there. And in another indication of her spirit of doing what is right and not being deterred by norms that don't align with that, she didn't think the local fraternity breakdown scene was necessarily what she thought was best, so she founded the first co-ed fraternity/sorority on the Brown campus, and 30 years later it's still functional. So someone who does innovative things that endure has certainly been a key feature of Dr. Feldman. She also met Hillel there, who's with us today, and that partnership has been a thing that has spurred her on, supported her, and it's been fun to me, even in talking to Hillel, just to see the fruit of that in her life, and we celebrate them as a couple today, certainly. There are many things Liane loves. Some of them we know about and get to experience. Some of them you might not know, but sports, family, travel, they've been all over the world. They've used speaking engagements that Dr. Feldman has had to study other cultures and places as a family and to enjoy them. I'm told that from her early experiences, I learned this through Jerry Freed with planning the first living kidney donation procedures that were done in a minimally invasive fashion at McGill, all the way from things like that to planning the itinerary of a family travel event. Liane gets into the details and does everything with excellence and focus. She also loves food. Some of us have learned to celebrate that with her at events in Sages. When we had our virtual retreat with the exec this past year, she taught us all how to make waffles and actually had Canadian maple syrup shipped to us. And she and Hillel and family have enjoyed a retreat at a little lake there in Canada for I think about 20 years now. It's been their escape on weekends. It's where they hit their restore point And this love of these things has been something she's passed on to others, including her children. Maybe something that appeals to a surgical audience, I learned that Dr. Feldman has her own instruments for pumpkin carving, and each year makes a pumpkin with each of her children. And you can see from looking at these that her artistry and skill are not confined to what's done through a laparoscope or in an abdomen. She is a surgeon and leader extraordinaire. She is someone we've all come to view as an exemplar. Her colleagues at McGill, obviously one of the most storied institutions in medical and surgical education, have celebrated her many accomplishments there, and many in the audience, some of you are in these pictures, have been mentored by and deeply influenced by her. She's one of those people who not only on national stages has credibility and influence, but has earned that clearly by her day-to-day work where she is. She's become an exemplar, as I said, and a friend and a mentor to many in this society. And we've learned to celebrate those things that she does day in and day out as part of what we've benefited from as a society. She's an encourager in tough times. And this past year during the COVID crisis, her local leadership there, as well as in Canada in general, as a surgical influencer, and especially to us as a society, has been seen on many fronts, including early publications about how to manage the practical and educational implications of the pandemic. She's an amazing scholar and, of course, is now chair at McGill, the first woman to hold that role. She has been an international leader, as this audience knows, in enhanced recovery strategies and technology-enabled assessment and enhancement of operative performance issues. She's a leader in many societies, including our own, and has published over 300 scholarly works, including 3 books. As I mentioned, she was the first woman to be appointed chairs at McGill, again, in line with her hockey interests. Liane didn't do this to be the first woman. She did it because it was a great thing to do, and she was worthy of it. And again, her example of that on so many fronts is something that has inspired us all. I'll close by just saying some things that I got from some of her colleagues, and I'll particularly thank Jerry Fried. These are just some of the things he used to describe Dr. Feldman. One of the smartest people I've ever met, not just in knowledge, but in her moral compass and her emotional intelligence. What an amazing set of skills for a leader. She does things not just because they are hot or politically correct, but because they are the right thing to do, and does them with conviction and impact. She writes beautifully, which is a lost art in medicine. She strives for excellence and the highest standard in everything she does. She's an outstanding chef and triathlete and doesn't back down from any challenge. And by the way, she learned to be a triathlete at age 50. Think about that and what it means for an adult learner. And finally, amazing tribute. I learned more from her than I ever taught her. Dr. Feldman, we've all learned more from you than we've ever contributed to or taught you. We welcome you to the stage and look forward to learning once again. Sages, this is your president, Dr. Liane Feldman.
I feel like I don't have to say anything. I'm done. I'm done. That's it. I don't need to say anymore. Thank you for coming to the session. Thank you, John. I hope I do that introduction justice, but and especially coming from you, someone I've admired and learned from so much for the last many, many years. So thank you so much for doing that. I'm not sure I'll get through this, but we've had precedent from the stage, so I'll do my best. I'm really just so thrilled and grateful to be with so many of my Sages family here in person and we don't take that for granted anymore. And with many others joining virtually from around the world, including my parents, Ron and Sandra, in Florida, my son, Zach, in Toronto, my daughter, Ari, in Vancouver, my son, Jonah, in Montreal, and many others joining in our first fully hybrid SAGES meeting with every session live streamed and recorded to hopefully increase access to the amazing educational materials at our annual meeting. When we started to think about what we wanted this meeting to be about, we landed on the theme of Welcome Home, SAGES. Perhaps the universe laughed a little at the idea that we would all be physically reunited here in Denver, and we're not completely back to normal. But home is not only a physical space, it's a sense of belonging, of community, of connection. Home is where you feel the most yourself, where you can express yourself, where you're with your people, where you're appreciated. A sense of belonging is a very human need. We all need to feel connected to a community and feel part of something bigger than ourselves. But it's also okay to be sad for what we've missed and continue to miss. I look forward to seeing my SAGES family here every year and at other times of the year at our retreats, at our summits, at our courses. These events that bring us together are always so energizing and inspiring. And yes, we've compensated in some really amazing ways and have managed to accomplish so much, but clearly it's not the same. Emile Durkheim, one of the founders of modern sociology, talked about the concept of collective effervescence. That describes that sense of electricity and energy when we are engaged as a group around a shared purpose. I think this pretty much captures it. But it's not just at the sing-off where we experience this feeling. It's in the coming together to devise creative educational programs, plan research, solve problems, learn new techniques, share what we're passionate about with other people who are equally passionate. So what makes SAGES feel like home for so many of us? We have a connection to a common vision, sagifying the world, reimagining surgical care for a healthier world. To our mission, to innovate, educate, and collaborate to improve patient care. And to our values, inclusivity, innovation, service, excellence, global community, and fun. I was first introduced to SAGES as a fellow and came to the 1999 meeting with Jerry Fried and his wife, Karen, who's also watching, I think. By that time, I'd been to some other conferences, and they were all very exciting, but I immediately connected with SAGES. MIS was still relatively new then. I loved the focus on these new techniques being described by the people who were developing them and being able to talk and interact with them. Perhaps because it was a lot less formal and seemed to involve a lot of younger people, including in leadership. Some of them brought their kids to the meeting, like Joe Beisky did in 2004 with her 4 kids when she was the program chair. That was the previous time SAGES was in Denver. Of course, a sing-off instead of a black tie dinner. For me, as you've seen, someone who is attracted to surgery partly because of the opportunity to wear pajamas all day, I immediately felt SAGES was my home society. But SAGES is no longer that upstart, renegade endoscopy and laparoscopy society. And we need to ensure that even as we've grown, SAGES still feels like home for everyone. An inclusive society where we continue to attract a diverse community of surgeons to minimally invasive GI surgery and support their professional and personal growth. A place where you're encouraged to express what is unique about you, and those things are seen as assets, not things to hide, and not things that we hope other people tolerate, but things to celebrate. People with a wide range of backgrounds, experiences, viewpoints, practice types, and expertise that bring a range of perspectives that inspire creativity and innovation, and making sure full participation is available and encouraged for everyone who wants it. That's good for SAGES, but applying what we learn here at SAGES in our clinical, academic, and leadership roles at home is how we expand access to advanced surgical care for all our patients, and maybe even help drive some needed changes in surgical culture and practice. Most importantly, SAGES is people, and here are just a few of them.
Hello, fellow SAGES members. I'm Dr. Danielle Walsh.
I'm Steve Wexner.
I'm Anjali Kumar.
Ross Goldberg.
Alina Vasiliou.
David Urbach.
Jerry Freed.
I was born in Colombo, Sri Lanka.
Danville, Indiana.
Geneva, Switzerland.
Philadelphia, Pennsylvania.
From Sofia, Bulgaria.
Bingham of the United Kingdom.
Laramie, Wyoming.
St. Louis, Missouri.
My practice is foregut surgery, primarily esophageal cancer.
I do minimally invasive elective general surgery.
I'm an academic endocrine and acute care surgeon.
I'm a colorectal surgeon.
I was primarily focused on surgical endoscopy and minimally invasive surgery.
I'm a bariatric minimally invasive surgeon.
I have a hybrid academic as well as community practice.
I am a foregut flexendo bariatric surgeon.
I've been a SAGES member for 12 years.
For 10 years.
Since SAGES began.
13 years.
Starting in 2003.
36 years.
Over 11 years.
28 years.
And if there's one word I can use to describe SAGES, it is progressive.
SAGES rocks.
SAGES is inclusive.
Teamwork.
Relevant. SAGES has been remarkably and consistently relevant to my career throughout all the decades.
Opportunity.
Fun.
Innovation and family.
For SAGES, which is service to our future generations. Thanks again.
I'd like to spend my time with you today sharing some thoughts about changes in surgery. The dictionary definition of revolution is a sudden, radical, or complete change. But as Angelica Schuyler says in the musical Hamilton, you want a revolution, I want a revelation. As we go through periods of rapid change, what lessons do they reveal? And of course, the word revolution includes the word evolution, defined as a process of continuous change from a lower, simpler, or worse to a higher, more complex, or better state. So how should we incorporate the lessons learned in times of rapid change to evolve surgery and our lives as surgeons? I'd like to frame this using the three overlapping and connected elements of our SAGES mission: to innovate, educate, and collaborate to improve patient care. Innovate. So during the pandemic, I started listening to more podcasts, on those endless COVID walks. I readily admit to being a surgery nerd, so some of my favorites are surgery podcasts, basically the only podcasts I listen to. Like the really awesome, if you haven't listened to this already, SAGES Stories that started this year. Yeah, hosted by Dr. Shirin Tofai and Kevin Al-Hayek. It's fantastic. And I really love the Legends of Surgery podcast. It's more than 100 episodes, but they're pretty short, about the history of surgery. If you ever wondered why scrubs are green, or who was Nissen, or who was Metzenbaum, this podcast is for you. Learning about surgical history and our lineage helps us gain deeper appreciation for where we come from and where we are now. Of course, till quite recently, surgery was mostly characterized by its brutality and incredible risk. And although surgery has evolved over thousands of years, there are significant inflection points that radically transform surgery in a short period of time. And many think we're at the brink of one of those points now. Two occurred in the 19th century and made modern surgery possible. A few months ago, October 16th, 2021, was the 175th anniversary of the first public demonstration of an operation performed under ether anesthesia in 1846. Before this, the most important quality a surgeon could possess was speed. The famous British surgeon, Robert Liston, could do a leg amputation in under 30 seconds. Besides the unimaginable pain, the mortality rate was shockingly high, around 50% for amputations, and sometimes even higher. During one famous case, in amputation of a leg for gangrene, in his haste, Liston accidentally also amputated one of his assistant's fingers, who was holding the patient down, and also lacerated a senior surgeon who was observing. All three, the patient, the assistant, and the observer, died of sepsis, making this the only known case with a mortality of 300%. Then, in 1865, Joseph Lister carried out his first operation with antiseptic technique, using carbolic acid for hand washing and dressings and as a spray over the operative field. The mortality rate for amputation fell from 50% to 15%. As with many surgical innovations, antisepsis was initially greeted with skepticism, and it took time for the surgical establishment to adopt. But with anesthesia and antisepsis, meticulousness and attention to detail could replace speed and brutality as the main characteristics of surgeons. Modern surgical techniques and training developed quickly in the 20th century with really obviously many amazing breakthroughs. But it's also been argued that the introduction of minimally invasive surgery and the emergence of computer and robotic-assisted interventions at the end of the 20th century was an advance as significant to the course of surgery and medicine as anesthesia and antisepsis were in the 19th century. Over the last 3 decades, we've seen an incredibly rapid evolution in practice and outcomes as surgery has become increasingly less invasive, more precise, more predictable, with faster recovery and less risk. However, in many important ways, surgery remains a craft. Yes, we now work in operating rooms with an enormous array of advanced equipment to perform procedures and monitor patients, and electronic records have a huge amount of data on each patient, including comorbidities, lab results, imaging, as well as outcomes data. But this data is incomplete, unstructured, and unconnected. Each surgical team filters all this information and uses their individual knowledge, experience, and intuition to deliver the best care they can for each patient. The devices we use, whether endoscopic, laparoscopic, or robotic, are used for the individual patient in front of us. The next surgical revolution will be fueled by connecting this all together, integrating data from millions of data points from around the world, incorporating data sources that until now we haven't been able to really exploit, including what happens in the operating room from procedural video or kinematics data, and data directly from patients through wearable sensors and patient-reported outcomes that will track and even predict recovery and complications. Ultimately, linking preoperative, intraoperative, and postoperative data will close the feedback loop and inform upstream surgical decision-making, including patient selection and risk prediction, as well as potentially provide decision support during performance of the operation itself. This interest in procedural video, it's not new to us as MIS surgeons. It's a foundational tool for education and inspiration in minimally invasive surgery, and it has been from the very beginning. In 1989, the SAGES laparoscopy revolution started when Jacques Périssat showed a video of laparoscopic cholecystectomy in the exhibit hall of our meeting, and the room of surgical innovators, some of whom are here today, immediately grasped the implications of what they were seeing. Laparoscopy made it easier to record and share procedures, and videos have always been a big part of SAGES. At panel sessions, on SAGES TV, on YouTube, and Facebook groups, we want the experts to show us videos of the perfect operation where we can pick up those pearls that lead to those great results. When I'm faced with something I don't do very often in the OR, I Google and look for a SAGES video to prepare for that. And I know many of you, if not all of you, do the same. And we also want to see those videos of complications, where you hear that gasp in the room, and we all think, there but for the grace of God go I. But I want to see how that happened, so it doesn't happen to me. And if it does, I want to see how to fix it. Yes, laparoscopy made it easier to record procedures, but what can we do to maximize the impact from that? Like me, probably many of you have stacks and stacks of VCR tapes and DVDs, I might be dating myself a little bit here, or external storage devices with lots and lots of videos on them. So there's a lot of data out there somewhere, including in this box that I've carried from office to office for the last 20 years. I don't know why exactly, where I found a VHS tape. I knew it was there, but I didn't know exactly where it was, but I looked for it. And it took a bit of effort, but this was what was on that. Now you can see that this is a pretty easy gallbladder, nice blue gallbladder. We're happy to see that we put the scope in there. But you can also see that this is not a very slick procedure. And it doesn't take an expert to know that. I think we could crowdsource that, and people would recognize that this is not a master surgeon or even a competent surgeon. This person is obviously very lost. And like there's no tension on that, there's like no exposure. Yeah, you might have guessed, but this is me. This is the first lap chole where I got to do the triangle of Callot dissection as a junior resident with a very patient attending. And most of you probably know who that is. Anyone I've operated with more recently, and many of you are here, will know that my technique as well as my tolerance have changed significantly since then. I am not that patient attending. Expertise is about developing rich mental models to be able to quickly interpret and react to what we see and predict what's going to happen next. Reviewing and learning from videos is an incredibly rich source to build these models. But beyond the benefits to us as individual learners, procedural data is also being used to develop computer vision algorithms that may someday be able to augment surgical decision-making and safety, so that the knowledge that takes years for the master surgeon to acquire is available to everyone when they need it in the OR. Algorithms have been developed to automate identification of procedure steps, identify adverse events, recognize the critical view of safety, and even to identify safe zones for dissection. It's important that surgeons be involved in developing these tools from the beginning. While many algorithms have been developed, one limitation is that they're very rarely validated on other data sets. This week, our AI task force, led by Drs. Oz Morales, Dan Hashimoto, and Paresh Shah, along with an incredible team of global collaborators, launched an inaugural Critical View of Safety Challenge to evaluate algorithms for automated assessment of the critical view of safety from lap chole videos. To run the challenge, SAGES will collect, annotate, and release 1,000 lap chole videos. This alone will represent a significant contribution towards the development of AI tools of surgical value. So please consider donating a video to this project at cvschallenge.org. Surgical data science is a new field to improve the quality and value of surgery through the capture, organization, analysis, and interpretation of data. This year, we established a Surgical Data Science, or SDS, task force led by Drs. Amin Madani and Aurora Pryor. The goal of the task force is to explore the potential for SAGES to create or collaborate to create a shared global repository for surgical data, providing access to a digital backbone for our members to pursue research, education, and quality improvement initiatives. The SDS task force will work closely with the AI task force and the Tech Council's digital health group to bring this all together. So what can we learn from previous surgical revolutions, like the MIS revolution, as we're on the cusp of this data science revolution? First, that surgical innovations are tools in service to improving safety and outcomes for patients. They don't exist just to exist, and they need to be evaluated from this perspective. I entered surgical residency in the early 1990s, and what drew me to MIS was the amazing difference I saw in patients compared to having open surgery. For me, it was about using this exciting new approach to improve patient recovery. But it wasn't just the change in surgical technique that made the difference. The whole attitude toward perioperative care shifted when we used laparoscopy. We knew that there was less of a metabolic response to surgery with laparoscopy, less pain, less ileus, so we started to change the way we took care of patients after laparoscopic surgery. We started feeding patients earlier, reducing the amount of tests, encouraging patients to be more active, shortening hospital stay. And also, we expected patients to recover faster, and they expected to recover faster too. But it turns out that some of those elements of traditional perioperative care that were drummed into me during my training as being the cornerstones of safe surgical practice, I mean, you get fired for when you took out an NG tube, were actually not helpful no matter what surgical approach you had. Many were based more on traditions than evidence, and some can actually be harmful, like delaying nutrition for days, using large amount of IV fluids, basing analgesia techniques on opioids alone. At McGill, we developed our first perioperative pathway for laparoscopic foregut surgery almost 20 years ago to make sure, basically, that these patients receive different care than after open surgery. But what also happened was that changing care after laparoscopic procedures started to impact our approach for patients having open surgery as well, and some traditions began to be questioned. At the same time, the benefits of enhanced recovery after surgery pathways, really as a strategy to implement evidence-based perioperative care, was shown to significantly improve outcomes and value across many types of procedures and healthcare systems. So what were those innovative, practice-changing technologies driving the excellent results with enhanced recovery pathways? Probably multidisciplinary team meetings and using standard order sets. We tend to equate innovation with invention, and no doubt the MIS part was and still absolutely critical to improving recovery. And SAGES remains passionate about identifying and supporting surgeon innovators and inventors through programs like the Shark Tank, the finals of which are tonight. But continuing to refine existing processes is also critical. David Sachs writes that true innovation isn't just some magic carnival of invention. It is a continuing process of gradual improvement and assessment that every institution and business experiences in some way. Often that actually means adopting ideas and tools that already exist but make sense in a new context, or even returning to methods that worked in the past. Adapted to the challenges of today, these rear-view innovations have proved to be as transformative as novel technologies. SAGES embraced the concept of enhanced recovery pathways through developing the SMART program, which was created to support wider adoption of these concepts for minimally invasive procedures. Through the Quality Outcomes Safety Committee, chaired by Dr. Jonathan Dort and Debbie Keller, and championed by the Opioid Task Force, led by Dr. Tanya Young-Fadak and Dr. Gina Andralis, we were very excited this year to launch opavoid.org, an amazing resource including videos, patient information, and prescribing resources to support surgeon adoption of techniques like tap blocks and other blocks to facilitate opioid-sparing analgesia, key ERAS principles. And a revamped SMART website is also coming soon. Educate. Another lesson of the MIS revolution was the need to design new approaches to surgical education. Transitioning from standard open surgery to laparoscopic surgery required that a generation of surgeons in practice not only had to learn the technique safely themselves, but teach it to their trainees. It was way back in 1997 that SAGES created the Fundamentals of Laparoscopic Surgery Committee, and I think some of the original chairs are here with us, to create a program to teach and assess the knowledge and skills required to perform laparoscopic procedures. The development of FLS was an important benchmark in surgical education, as it established a competence level and a verification process, in contrast to the usual approach of just assuming competence when a course, rotation, or certain number of cases are completed. And a similar rigorous approach was used to develop the educational and assessment programs FUSE and FES. To date, over 22,000 people have met that standard and passed FLS. With advances in surgical techniques and trainee exposure, some have rightfully questioned whether FLS is as relevant today as when it was originally designed 25 years ago. So the FLS committee, led by Drs. Melina Vassiliou, Neil Seymour, and Alan Okranik, have embarked on a very detailed examination of the current role of FLS, and FLS 2.0 is coming soon. A new EPA-based framework aligned with current MIS practice will guide the entire program. This includes web-based interactive didactics that you will actually want to use, an EPA-based curriculum to support educators and learners, and an updated multiple choice exam with new questions. And the skills exam is also changing. You heard it here first, with the extracorporeal not tasks removed and refined metrics and testing logistics. The virtual testing option is also here to stay. SAGE's fundamentals programs are about foundational surgical skills that should be established early on in training. But surgeons need to continually learn and improve throughout their careers. The first step in improving something is to be able to measure it. So SAGES has embarked on a project to create procedure-specific video-based assessments, or VBAs, that are supported by high-level validity evidence, envisioned as a part of lifelong learning and improvement for surgeons. We started with fundoplication as an important procedure for our members and our MIS, bariatric, and foregut fellows. One key element in creating, and perhaps the most important element in creating these tools, is to make sure we're measuring what is actually important for safe and effective fundoplication surgery. Under the leadership of Dr. Matt Ritter, the first step was interviews with almost 45 international experts. Then over 180 SAGES surgeons completed a survey to define critical procedure steps, skills, and errors. A core development group combined this into a rubric that has 5 key steps in columns and scoring for each step that includes skills, safety, and quality. Videos were donated by SAGES members to develop the scoring system, and a collaboration with the Surgical Video Analytics Platform facilitated sharing and scoring the videos. Working with experts from the Foregut Committee, the team has developed reliable rater training and are now defining a pass-fail cut score. Ultimately, we plan to develop VBAs for procedures that are important for our members. This will be led by the assessment group of the Education Council, chaired by Drs. Denise G. and Carlos Gomez-Garibello. The next one will be for laparoscopic cholecystectomy, and we're establishing a collaboration with ASMBS to create a bariatric-specific VBA. So how can this all fit together to support surgeons in continuous improvement throughout their careers? We're excited to partner with the Academy for Surgical Coaching to develop a video-based peer coaching program in robotic and laparoscopic fundoplication. This weekend, we'll be training 30 peer coaches and hope to enroll about 40 early career surgeons as the first coaching community. So please look out for that. 4 years ago, we set out to strengthen the structure of our vast educational offerings by unifying and streamlining delivery of our content onto an organization-wide learning system, OWLS. I'm very happy to announce that this will be available to SAGES members starting this Monday, March 21st, my son Jonah's birthday also. We're incredibly grateful to Dr. Pond for his transformative donation and to the SAGES Foundation for their support. And thank you to Dr. Steve Schweitzberg and Vanessa Pryor from SAGES for your persistence to get this across the finish line through many challenges. With OWLS, SAGES will become your portal for online learning, anywhere in the world, on any device, 24/7. You will now be able to navigate to SAGES TV, browse the SAGES image library, register for a fundamentals exam, view didactic material, and claim CME, all from one place. Through OWLS, SAGES will deliver FLS, FES, FUSE, and Safe Coli, as well as new and future programs like the FUSE Hospital Compliance Modules, SAGES Question Bank, and the Master Series. The Master Series is developing disease-based curricula along 3 levels of increasing expertise: competency, proficiency, and mastery. Each pathway has preoperative, intraoperative, and postoperative modules, and an assessment module, including a VBA. It combines and arranges our vast library of educational resources in an interactive, learner-friendly format. Earlier this week, we were able to get a quick peek at the preoperative and intraoperative interactive modules for the foregut competency pathway, and I wanted to show you a little video of that, but it just really didn't do it justice, and it's something you just really need to interact with. So I know that you'll all be excited to start doing that. Collaborate. Collaboration includes working together to ensure equal access to advanced surgical technologies that improve care. The pandemic shone a spotlight on many of our failures as a society in general, including the impact of systemic racism on health outcomes, global inequities, and really how we treat the most vulnerable among us. Of course, these are not new issues, but the crisis exposed the cracks. We're all here because we strongly believe that MIS provides better outcomes, faster recovery, and fewer complications for patients. Yet there are so many examples of unequal access to MIS and endoscopy and unequal outcomes. To cite just a few, while African Americans have the highest incidence and mortality from colorectal cancer, they are least likely to undergo colorectal cancer screening. In bariatric surgery, African American patients have a higher BMI at the time of surgery and less favorable weight loss. After sleeve gastrectomy, have a higher mortality rate and higher rates of reintervention. Black patients have a significantly lower likelihood of undergoing an MIS approach for inguinal hernia, cholecystectomy, appendectomy, and colectomy. These discrepancies are in part due to differences in access to surgeons who offer minimally invasive surgery. Lower access to minimally invasive surgery in rural or lower income areas has also been documented consistently in many countries, including in Canada. So what role can SAGES play in addressing these complex issues? There is evidence that similarity in background or demographics between patients and physicians is associated with better health outcomes. While the reasons for this are not completely or well understood, there is some evidence suggesting better communication and more shared decision-making when patients and physicians are of the same race and gender. From the patient perspective, perceived similarity is associated with higher trust, satisfaction, and intention to adhere. No one sets out to provide different care to different groups of people, and these studies suggest potential strategies for improvement, such as techniques to better communicate with patients across diverse identities. But having a diverse surgical workforce will also help address disparities in access and outcomes. Yet, there remain fewer women and far fewer people from racial and ethnic minority groups in surgery compared to the general population. The proportion of men and women graduating from medical school is equal, and we now have about 40% women entering general surgery training. But women and people from racial and ethnic minority groups are at a higher risk of dropping out of training and of failing to advance academically. In the past decade, U.S. women surgical faculty increased from 19 to 26%, but the number at higher ranks remains low, with only 12% of women full professors and 5% chairs. And there has been little change in Black and Hispanic academic surgeons, with Black full professors increasing minimally from 2.2 to 2.5%, and Hispanic surgeons from 2 to 3%. And I'm very proud to be on the same stage as Dr. K. Marie King yesterday, who, as we know, this past year became the first Black woman academic surgical chair in the United States, and she gave an absolutely inspiring Mark's lecture yesterday. A diverse surgical faculty has been associated with greater diversity of medical students, suggesting that improving representation in our faculty leaders may be one strategy to improve diversity of our workforce. Now, I had never given a huge amount of thought to the importance of representation until I was appointed to my day job, my other little job, back at McGill. And as John showed, this made it onto the evening news, suggesting it is still considered a man bites dog type of unusual situation, at least for some. I look a little bit surprised, you know, I'm like, which shows that cultural expectations and beliefs are slow to evolve. We all have subconscious or conscious beliefs about who belongs in surgery, and they are deep. I dreamed of being a doctor since I was a little kid, undoubtedly inspired by my dad and uncles who were doctors. But a big part of what drew me to surgery was the TV show MASH. Again, dating myself, goes with the VHS and DVDs. About a mobile army surgical unit in the Korean War. I really especially loved Hawkeye, played by Alan Alda. Smart, funny, sarcastic, amazing surgeon working in horrific conditions. Of course he didn't follow the rules, but that was to protest the unfairness of war. So it was a bit of a shock when, as part of COVID TV binging, I started to rewatch the show. I guess I didn't notice the pretty abhorrent treatment and attitudes towards women, who are all nurses, when I watched it the first time. Now, it is true that Alan Alda did become an iconic feminist star as the seasons went on, but this was a very prominent part of the character in the early seasons. And we all perhaps incorporate these cultural stereotypes about who surgeons are and how they behave in ways that we may not even be aware of. But awareness is an important first step. Are we contributing to environments that attract and enable our students to see themselves as the kind of person who is a surgeon? In medical school, as John mentioned, my surgery clerkship rotation was one of my last ones. While I really loved the pace, taking care of sick patients, the camaraderie, and being in the OR, I wasn't sure that I wanted the life of a surgeon. But on one of the last days, we were a big team doing an open appendectomy, and I was handed the knife. That experience of opening and being trusted to put on a few ties, probably on the appendix side, I hope in retrospect, doing the case skin to skin, at least in my mind, was a critical moment for me. And when we were asked to think of those moments of belonging or connection yesterday, that was one that immediately popped into my mind, and maybe that was the same for some of you. And I just didn't think I would get that same sense of reward or be as challenged or fulfilled in other specialties, but I still feel that way. An important message from being handed that knife was that others saw me as a surgeon. We all need to be looking out for people who may have potential and explicitly encouraging and mentoring them. Surgical societies like SAGES also play important roles in supporting women and underrepresented surgeons in academic promotion and leadership. This includes opportunities to present research and publish in our journal and apply for peer-reviewed grants. This year, the SAGES Research and Career Development Committee, led by Drs. Chris DeCoyne, Anjali Kumar, and Dino Spaniolis, allocated $350,000 in peer-reviewed grants, including a new grant to research disparities in healthcare. Roles on committees and projects provide leadership opportunities and exposure, and the self-nominating process for our committees makes it easy for everyone who wants to get involved. Informal networking with international leaders at the meeting itself, like in the hallway, or at the Meet the Leadership event this evening. Speaking opportunities are markers of national and international reputation that are key factors in academic promotion, and certainly SAGES has played these roles for me. We need to make sure that SAGES continues to play that role for everyone. The We Are SAGES task force was initiated 5 years ago during Dan Jones's presidency to encourage diversity in our membership as a competitive advantage for innovative thinking and identifying organizational blind spots. This became the Diversity, Leadership, and Professional Development Committee, chaired by Drs. Leah Qureshi, Hope Jackson, and Jason Kuhn, to explicitly embed diversity and inclusion into SAGE's leadership training programs. The committee is hard at work on a fundamentals of leadership development curriculum, emphasizing mentorship, sponsorship, allyship, and health equity skills. And we also congratulate committee member Dr. Jenny Shao for obtaining a competitive grant from the American College of Surgeons to develop this for SAGEs. In November 2021, we were very lucky to hold in person a 2-day diversity and inclusion strategic planning retreat led by consultant Laura Lee. We wanted to create a roadmap to help us build in diversity and inclusion into all of SAGE's activities. We created action items across the organization, including membership, leadership, advocacy, research, awards, tech, training, and patient education. An obvious first step requires a reflection about where we are now as an organization and develop ways to measure this and respond to this in meaningful ways. In 2018, over 70% of surveyed SAGE's members self-identified as community surgeons. The Community Practice Committee was created to ensure that SAGE's continues to develop content that meets the needs for all our members. Under chairs Drs. Caitlin Halbert, Kevin Wasco, Mercedes Bagay, and Robert Catania, the committee has written a really excellent white paper and is launching a speakers catalog to allow program chairs to expand their pool of speakers and add diversity to the podium. We initiated a new award to recognize excellence in community surgery with Caitlin Halbert as the inaugural recipient. I'm also excited that SAGES has been asked to collaborate with the Society of Black Academic Surgeons under President and SAGES leader, Dr. Carla Pugh, on their fundamentals, her vision for a Fundamentals of Allyship program. We are proud that our SAGES fundamentals model may be the framework for this project and look forward to working with SBAS to support this exciting work. I'm proud of what we've done so far, and we are committed to continuing this work to ensure that SAGES will always feel like home for all of us. A final thought to wrap up. Wherever we are in the cycle of surgical revolutions, we are reminded that technologies, even really useful technologies, don't take care of patients and don't operate. Understanding a patient's goals and priorities, making a treatment decision with patients, and then executing the plan. Being there to support patients and families through some of their worst and most vulnerable moments, and to celebrate with them when things go well. And I am truly in awe of the support and grace patients and families give us, even when things don't go the way we want them to. This was a post from one of my first donor nephrectomy patients, who was one of our first patients just after we started that program over 20 years ago. This is a post she put on Facebook when I was announced as the chair at McGill. She had a complication that was hard on both of us and led to a change in my practice, and it's not happened since. But I, of course, associated her name with that complication on my learning curve. So to have her state that she was proud to be among the first in this program was very meaningful. And how we repay that debt to our patients, to our mentors and teachers who paved the way for us, and to our families who maybe don't see enough of us or get our full attention even when they do see us, is to continue to do the work to make things better. Continuing to learn and perfecting new skills and bringing them home. Mentoring underrepresented students, faculty, and staff. Teaching, doing research and quality improvement. And of course, one of my favorites, engaging meaningfully in organizations like SAGES. These are all ways we connect with each other and with the joy in our lives as surgeons, which you will hear more about in the upcoming sessions. I am so grateful for the immense, once-in-a-lifetime privilege to have served as your president this past year, and for all your encouragement, learning, friendship, and fun over the past almost 25 years. So thank you all. No, wait. I have a few thank yous. Let me expand on the thank yous a little bit. You'll indulge me for a few minutes. Thank you. First of all, isn't this meeting amazing? Yes, it is. And thank you to our program chairs, Drs. Archana Ramaswamy and Jake Greenberg, for all of their work to make this happen. And the entire SAGES meeting staff, starting with Carrie Ahern and her team. They planned 3, then 2, then 1 meeting, two meetings this year, hopefully 1 meeting this coming year, all these 2 years in a row, and really, they made it look like that was normal, and they made it easy, and they're so amazing. SAGES now has an astounding 47 committees and task forces, with 132 chairs and co-chairs, 45 board members, and over 800 committee members. As we've all learned, it's not easy to stay engaged over Zoom. I highlighted only a few projects from our committees here today, but all of our SAGES volunteer army has continued to have the passion to do an absolutely mind-boggling amount of work to move SAGES and surgery forward. Your service is truly awesome. No doubt that one of the greatest gifts of SAGES is the friendships. Through our time and work together, we've developed real and enduring relationships. You've given me opportunities, advice, encouragement, support, and definitely a few pushes out of my comfort zone. You know who you are along the way. There's a good reason why every president comes up here and expresses their deep appreciation for Sally Matthews and the 44 people on the SAGES management team. Anna, Brian, Carla, Carrie, Catherine, Christelle, Colleen, Dale, Dan, Deb, Dee, Denise, Ed, Erin, Heidi, Hillary, Holly, Inga, JQ, Jared, Jason, Jessica, Jillian, Julie, Kaylee, Kim, Lauren, Linda, Lindsay, Lauren, Marissa, Melody, Michelle, Monia, Nathaniel, Nicole, Roland, Sarah, Shelley, Vanessa C., Vanessa P., and Vera. Yep. 28 of them are here with us in Denver. You are the gold standard for keeping everything on track. All the priority projects moving along, and as we all know, everything is a priority. You're incredibly well organized. You accomplish so much. And Sally, you are the heart, the soul, and the brains of SAGES. Yeah. You have somehow managed to stay calm and cool despite many challenges of this ever-changing surgical world, and throughout the pandemic, despite all the unknowns and stresses on many levels. You always kept us steady and moving forward with optimism, patience, and resolve. You walk the walk for our SAGES values every day. Thank you, Sally. I was very lucky to have served on the SAGES exec these past 6 years with these amazing people: Danny Scott, Dan Jones, Brian Duncan, Jeff Marks, Aurora Pryor, Horacio Asbin, Fred Brody, Chris Schlachta, John Mellinger, Brent Matthews, Pat Silla, and Rob Lim. You are really mentors and role models to me. You each contributed something unique to me personally and enduring to SAGES. Rob Lim, and you can see us with our waffles and our special waffles, SAGES waffle maker. Rob Lim, you may have noticed, is not here this week because he's working to provide surgical and medical care in Ukraine. His life of service And if there are, we had our military symposium, and he was very involved in always organizing that and bringing that to SAGES. We had 60 people participate in that on Wednesday. If we have any active military here with us this morning, if you stand up, and we'd love to acknowledge you and continue to keep us safe. And I can see you're not here because you're doing more important work, but thank you. And you've seen some opportunities at this meeting to donate to organizations providing medical care, like the one Rob is involved with, the Global Surgical and Medical Support Group, or any other organization providing care in Ukraine or globally for refugees, and I hope that we all do so. When I was interviewing for general surgery residency, one of the interviews was at a very prominent program, and I was waiting in the hall for my turn to be interviewed when a department leader came up to me and in a very friendly manner asked if I was the wife of one of the people interviewing there that day. That went over well. Now, I can't say that was the main reason why I didn't end up there, but I can say that I never felt that way at all at McGill. I was lucky to be trained by many outstanding surgeons, including people like Dr. Ray Brown, who was a great friend and advocate for the residents and always protected us no matter what went wrong. Dr. Jacob Garzon, an early adopter of MAS, truly a master surgeon at the Jewish General Hospital, who had seen it all and could do anything and took me under his wing. There were 4 women faculty members at the 5 training sites in my residency. This included Judith Trudell, who was one of my program directors, and Carol Ann Vasilevsky, both of whom I saw pregnant during my residency, rounding in the ICU, operating, being on call, having young families that they brought to events, and that made an impression. But my main influence, mentor, sponsor since medical school has been Jerry Freed, who trained me, shared his practice, trained me, and you could see that took a fair bit of patience, shared his practice, supported my research, introduced me to people and opportunities, helped me in difficult times, and celebrated with me in good times. His love for surgery and for the academic life was obvious, but he was also a great role model for a balanced surgical life, where family comes first, vacations are taken, friendships are maintained, and tennis is played. I know I followed in his footsteps in our job titles, here and at home, but success for me would be to be able to be seen as a mentor for others the way he was and continues to be for me and for so many others. Thank you, Jerry. And thank you to all my colleagues from McGill who have come here to SAGES this week. Melina, Larry, who had to go home, he has a bad concussion, but I hope he's not watching this on screen, he's not allowed. Julio, Lorenzo, Amin, Mary-Lise, Allison, Sender, Miriam, Carlos, are all my colleagues from McGill who I know are here, and I hope I didn't miss anyone, because I'm so proud to see the amazing things you do at home and to see so many of you thriving and leading and participating in SAGES. I'm so grateful to our McGill residents, fellows, and graduate students for basically writing almost all of those papers and books, but lots of other things too, for what you've taught me. And I'm so proud to see you flourish in your careers and your lives all around the world. SAGES is really the place where our group presents our work, where we reunite, and where we celebrate success. And thank you to Peppa Caneva, who runs our research program, and so much more, and to Maria Cortez, who's actually retired, but we couldn't have that. So she's continued to be an amazing resource for our group and to me personally. Thank you, Peppa and Maria. I feel very supported. I've felt so supported by you both. I know you always have my back, truly. I'm very thankful to my parents, Sandra and Ron, who are always the biggest cheerleaders for me, our biggest supporters for me and for my brothers, Jamie and Adam, and wonderful role models. I always felt I could do anything. We were also very lucky to have them, as well as my in-laws, Myra and the late Jack Rosen, all in Montreal to be very present grandparents, and we definitely needed lots of help. Hillel, thank you for coming to your first SAGES meeting. We've been a great team for over 30 years, and even though you're very squeamish about surgery and medicine stuff, you never wavered when I said it was going to be surgery for me or at any of the other points along the way, and obviously could not have done this without your support and encouragement. And you can see the difference between March 2003, December 2021. We all know this goes very quickly, and it's very chaotic in 2003, and it's very not chaotic in 2021. And Zach, that's my chief resident baby. Ariel, that's my fellowship baby. And Jonah, that's my second year in practice baby. He was a little jaundiced there, but he got better. And here they are just at New Year's. You don't have a lot of COVID pictures, and now they all live in different places, but there's my chief resident baby, Zach, my fellowship baby, Ari, and Jonah, our baby. And they made gougere for New Year's, because very good with champagne. I'm so proud of the caring, smart, funny, good people that you are. Sometimes surgeon moms feel guilty, I think, especially coming to conferences. But I see each of your independence and your self-confidence, and I'm so proud of it. And also, you each know how to cook, paddle a canoe, and ski down a mountain, so maybe it was okay. Thank you all again for being here with me today. This has been an incredibly moving experience for me, and I am grateful for your support and your love. And this has really been memorable, something I'll never forget. We have I think we're taking a break for mimosas and have a couple of great sessions and talks coming up, including our plenary on the joy of surgery, and our Storts lecturer, Kevin Roos, who's a New York Times tech columnist, podcaster, and the author of Future Proof. So I hope we can reunite here in a few minutes. Thank you.